Good morning, good afternoon, wherever you are joining us from. Please note that this event is being recorded. My name is Nafissatou Diop. I am leading the Innovating for Maternal and Child Health in Africa IMCHA initiative. It will be my pleasure to be your MC today. I'm joining you today from Ottawa, Canada. I would like to begin by acknowledging that the land where I live and work is the traditional and ancestral territory of the Algonquin Nation. We are co-hosting today's event with the University of Saskatchewan in Saskatoon, Canada, which resides on Treaty 6 territory and the homeland of the Métis. We pay our respect to the First Nations and Métis ancestors of this place and reaffirm our relationships with one another. I would also like to acknowledge that you are all joining today from many places, near and far, and acknowledge the traditional owners and caretakers of those lands. Since this is a virtual event, I would encourage you to think about the land that you are on. As we get started, you'll see some side questions to answer to tell us a little more about yourself and also some thoughts on community engagement. Please take a minute to provide your answers. I will now give the floor to Heidi for some logistical instructions and go over the agenda. Heidi, over to you.
Sure. Good morning, good afternoon, everyone. My name is Heidi Monk, and I'll be helping to moderate some questions throughout the day. But to get started, a few technical notes. So as Nappy mentioned, the meeting is being recorded, and this includes both the plenary session as well as the breakout group sessions, which we'll talk a little bit more about later. So at the top of your screen, you can see a few icons that I'd like to walk you through. If we start at the far right, you'll see a circle that has a kind of a wheel icon, and this is where you can change your audio settings. So today's event is taking place in English and French, and I'm going to repeat myself briefly in French in case anybody's in the wrong language at the moment. Alors, bienvenue, cet événement se déroule en anglais et en français.
So welcome. This event is going to be held in English and French. You can change your audio settings at the top of your screen. Click on the icon on the top right that looks like a wheel, and that will allow you to select French as an audio setting. And you can participate in any of the two languages, of course.
You'll see a question mark. And if you have any IT problems, we have a help desk at your disposal. So you can send them a message by clicking on that question mark if you need any technical support. Also note that if your internet disconnects at some point, you can reconnect to the meeting at any time using the same link that you used to join us today. Next over, you'll see a little icon that says Slido, and you can use Slido to contribute to our discussion today. So right now, we have a Slido poll, which is open, and so you can answer a few questions about yourself. And we also have a question and answer tab. We'll be using the question and answer tab during the discussion, where you can submit questions to the discussants. If you're having any trouble with Slido, you can go to slido.com and enter the event code IMCHA, and you'll also be able to participate in that way. So let's take a look at today's agenda. We're going to start with a prayer, and then we're going to have some welcoming remarks. We'll have a presentation that dives into what community engagement entails for an IMCHA research project in Mozambique. This will be followed by a short discussion period. And then we're going to break out into 5 groups for about 1 hour to dive into different topics relating to community engagement. After this, we're going to come back into the plenary session, and we're going to watch a traditional jingo dance done in honor of strong mother and child relationships. We'll have a quick sharing of some highlights from the different discussion groups, and then we're going to move into our closing ceremony. All right, over to you, Nappy. Let's get started.
Thank you, Heidi. Now, let's see what the response to your slide questions have been so far. So, which country are represented today? Can we see the Slido response for the countries? Slide questions for the countries. Okay. I see Canada. I don't see I don't see. Well, at least we have a few countries that are coming in. So welcome to everybody joining us. We are very welcome to this conference. We really welcome you. And what about who is present in this event? Wow, we can see we have a very much variety of participants at this event. Welcome all, and we hope you really will be able to share your experience with us and among us. That's very interesting. Thank you all. Last question, what important aspects of the community engagement did you mention in your Slido? Next Slido, please. Ooh. Wow, there is a lot, but respect participation are big on the map for sure, but there are a lot of other different aspects that will be very interesting to dig into during the breakout session groups. So thank you all for your response to the Slido questions. Now, I would like to thank Elder Judy Pelly for attending today's conference and offering a prayer from Treaty 6 territory, homeland of the Métis. Let's listen together while Elder Judy Pelly says a prayer for today's event. Elder, over to you.
Thank you very much. I really feel honored to be a part of this discussion today. I'm from Saskatoon. I'm Judy Pelly, and I'm a residential school survivor, as well as I've lived in Saskatoon for about 50 years, and I'm very involved with community engagement in the city, as well as working with a very vulnerable population. I work with a lot of mothers at risk and a lot of mental health and addictions in particular with the Saskatchewan Health Authority. I also belong to probably about 30 to 40 committees. I work with the post-secondary institutes. I work with several researchers. So my heart is in my work, working with a vulnerable population, a lot of young mothers. And as you know, that Indigenous people in Canada are very overrepresented in the healthcare system, in the criminal justice system, as well as child apprehension. So I look forward to really listen to the conversation about this area and around the world. And like, again, I thank everybody for this. And just before this started, traditionally when we say our prayers, we use smudge, we do smudging, and then we as Indigenous elders say prayers with our families. And this morning I did that at just before 7:30. I smudged and we don't record, we don't allow people to record our cultural ceremonies. So just rest assured that I did pray, and I just wanted to share that I prayed that we would start our session in a good way, and that we would all keep the people that don't have a voice in our prayers, people that are vulnerable, and especially children and young mothers, and all those people suffering from mental health and addictions. I prayed that all of us would stay safe in this very strange time in our history, especially with all over the world globally. Our world's changed this last March, and the world as we know it has changed. And I just wanted to say, that I feel blessed that we have ways of connecting with. I'm on Zoom almost every day, 3 or 4 times a day. So it's kept me connected with my community and also the elders in Saskatoon that many have connected also with technology. So that's really good to see. I belong to an elder survivor group, and we pray together for the goodness and wellness of our communities. And with that, I just want to say, Creator bless you all, and have a great meeting. Thank you.
Thank you very much, Elder. Now, I would like to introduce Dr. Darcy Marcinyuk, Associate Vice President of Research at the University of Saskatchewan. Dr. Marcinyuk, the floor is yours.
Well, thank you very much, esteemed colleagues, guests, Elder Judy Pelly. I'll just stop and make sure that you can hear me. Excellent. Let me begin by thanking the organizers for allowing me to be with you this morning. I'd also like to pay respect to our Indigenous heritage peoples and their voices. Community engagement, meaningful and genuine, is foundational to both our institutional research and internationalization strategies. Global health cannot be achieved by only working in your neighborhood or community alone, and the needs and barriers that exist for so many cannot be fully appreciated from just reading a book or looking at pictures. The University of Saskatchewan is committed to putting our knowledge to work to share our expertise, our people, and learnings derived from research and other scholarly activity with others around the world. We value partnerships, interdisciplinary collaboration, and leadership to inspire communities and their people to be all they can be. We're also committed to uplifting indigenization by more than just words and beyond the near future or this short term. The COVID-19 pandemic has highlighted the importance of sustainable partnerships in health more than ever before. The University of Saskatchewan is devoted to serve the global needs of our society and working hard to prepare our students, faculty, and staff to appreciate, recognize, and reflect on society's most important challenges. For example, our Vaccine and Infectious Disease Organization, International Vaccine Center, VIDO Intervac, one of the world's largest and most advanced level 3 high containment facilities, is on the front line for developing vaccines and therapies to combat the COVID-19 pandemic. Researchers and teams in the Innovating for Maternal and Child Health in Africa initiative, as you know, have similarly been working with communities to empower them to become agents of change and increase access, utilization of health information and services. We are proud of the contributions of the University of Saskatchewan team led by Dr. Ron Siemens for their ongoing work. The event this morning is an opportunity to reflect, to share learnings from this work, not only to improve the work of the team in Africa, but to inform and enable other teams in Canada and beyond. The collective experience in this virtual room alone will help us advance in these areas of health and build innovative thinking to create global solutions for health. For those of you who haven't already done so, I hope you'll be able to visit Saskatoon and the University of Saskatchewan in the future, once travel resumes and the world returns to a better and improved normal. Saskatoon is well known as the Bridge City, and the University of Saskatchewan and our dedicated faculty, staff, and students are also building bridges to connect with the world to make it a better place for us all. Let me close by saying thank you, and I wish everyone a successful and rewarding meeting.
Thank you very much, Dr. Marcinyuk. Now, the Mayor of Saskatoon, where the University of Saskatchewan is located, will say a few words. Mayor Charlie Clarks, the floor is yours.
Good morning. Greetings to everybody, and thank you for giving me an opportunity to join in with this international conference. When I was asked to participate from Dr. Siemens and have a chance to make the link with a lot of the work that we've been doing in Saskatoon with the work that this conference is about in terms of making the global and local connections on maternal and child health, I did want an opportunity to be able to thank you and to speak to the importance of this work. I really want to thank Elder Judy Pelly for her words and prayers in helping us to get off on this conference in a good way. Our elders in Saskatoon have been playing such an important role in helping connect us directly to the realities and experiences of community members, and as Elder Pelly said, keeping us all in our prayers as we try and change and improve systems to have better outcomes for families. The history of the Mozambique project, for example, which I know Dr. Siemens has been working on for many years, and we have had a number of different community members working here with the university and with partners in Mozambique, has been a real example to me of how we can strengthen these bonds and knowledge sharing and capacity between countries in identifying how to best improve systems to have the outcomes that we need for families. And it's been remarkable to watch students who are studying at the University of Saskatchewan travel to Mozambique and have their lives and perspectives changed as a result of spending time learning from the leaders and the clinicians in Mozambique, and also looking at ways that we can support and help in sharing some of the knowledge and learning and research that's happening in Canada with Mozambique. I've also had a chance to meet leaders from Mozambique who've come to Canada and been part of plenaries and conferences and discussions in Saskatoon, and learned from those conversations a great deal about some of the realities that are being dealt with. This is and how these connections are helping to build a stronger world. And so I'm very pleased that the University of Saskatchewan has been identified as the host of this conference, so that we can continue to look at how to expand these types of partnerships. The City of Saskatoon has signed a memorandum of understanding with the University of Saskatchewan out of a clear understanding that universities and communities should not operate as silos, but are very interdependent in terms of how do we solve the problems and address the challenges that exist within communities, and make sure that the research going on at universities is applied directly to community issues. And we're seeing a real need within our community, just as around the world, around making sure that more youth are getting through school, graduating, and being successful, starting off at the early years, as opposed to ending up incarcerated or in jail, or as we have in Saskatchewan, a real challenge with youth suicide. We need to be applying all of our knowledge and expertise at how do we help support families to succeed? How do we take the brain power and resources of university research and apply them directly to in direct engagement with community leaders and families facing these issues, and come up with better approaches to address the systems that are failing. I see this conference where we can share ideas from across our communities and across our countries as a really critical example of that. And I'm proud to have a chance to celebrate the leadership within our own community through some of these projects and through the university that has been doing that work. So Nappy, thank you, and Heidi, and Dr. Marciniak, and everybody, and Dr. Siemens, who's bringing this event together. It's different to not be face-to-face, but I hope everybody can make the very best of this by having engaging and honest conversations about how we can learn and grow together. Thank you very much. Take care.
Thank you very much, Your Worship. Now, I'm giving the floor to Dr. Aravind Kumar, Director of Inclusive Economy at the International Development Research Center, IDRC, where I work. Aravind, the floor is yours.
Thank you so much, Nappy. Thank you, Mayor. Thank you, Elder Judy, colleagues from the university, Professor Darcy. It is a different type of meeting, but it's wonderful to be connected in this way. And thank you for your kind words. Good morning, afternoon, evening to everybody participating. It is truly an honor. I feel humbled to be able to welcome you to this webinar on behalf of the initiative that Nappy leads, which we call IMCHA, the Innovating for Maternal and Child Health in Africa, which is a partnership between 3 Canadian governmental agencies, Global Affairs Canada, the Canadian Institutes of Health Research, and Canada's International Development Centre, my organization. My name is Aravind Kumar. I am the director of the program that's called Inclusive Economies, which this IMCHA initiative is a part of. Welcome everybody. Two things very briefly by way of introduction, because I look very much forward to the learnings that are going to come out of this. A little bit about Canada's role in international development and the IMCHA initiative. The Government of Canada supports gender equality, maternal and child health, and sexual and reproductive health and rights as part of Canada's engagement in the world. 98% of maternal deaths are preventable, and a large portion of children's deaths are also preventable. And most of these deaths take place in developing countries. This is why at IDRC, with our partners, we understand maternal and child health and sexual and reproductive health as being fundamentally connected to gender equality and to equality in health. All women and children, regardless of where they live, how old they are, whether they are married or not, or how much income they have, deserve access to respectful and high-quality health services. Women and children, particularly those from vulnerable or disadvantaged populations, have the worst access to quality care and health outcomes. In Canada, for example, as Judy, Elder Judy already referred to, Indigenous women are highly disadvantaged. They, for example, have double the maternal mortality rate when compared to non-Indigenous women. And of course, as was referred to during the current pandemic, these differences have come out ever more starkly. As part of Canada's commitment to gender equality and maternal and child health, 3 Canadian government organizations, as I said, the Canadian Institute for Health Research, Global Affairs Canada, and the International Development Research Centre, launched the initiative Innovating for Maternal and Child Health in 2014. IMCHA is a partnership between Canadian and African scholars and practitioners. Each of the research teams is led by an African principal investigator working in collaboration with a Canadian researcher, and also with co-principal investigators and an African decision maker as part of those teams. The initiative IMCHA supports 19 research teams working in 11 countries in sub-Saharan Africa and works with 2 regional organizations. Together, those partners working in those countries have been working to generate evidence in a number of topics that are of key relevance to maternal child health in particular context, and use this evidence to influence policies and practices to improve maternal and child health. The kind of collaboration that the mayor was talking about between universities and local authorities. Today, we will dive into the work of community interventions to exchange experiences and lessons learned. IMCHA teams engage communities in different ways. Some teams tested ways of working with community health workers. Some supported male and female champions. Some used theater, radio, educational soap opera, videos, etc. Other teams tested the use of mobile phone applications. And very important, very significant results are coming out of this work in community engagement. For example, in an intervention in Edo State in Nigeria, the number of women attending prenatal care increased by some 300% thanks to a series of interventions from one of the research teams to help detection and referral of high-risk pregnancies. Working with communities was instrumental in raising awareness about the importance of women and children's health. For example, in Senegal, the IMCHA research team there supported women leaders known as Badianou Cox. I'm probably not pronouncing this right. I'll be corrected on that. Supported as women leaders to raise awareness about maternal and child health. They are Badianou Cox are respected women in their communities whose leadership allowed them to contribute to shifting norms relating to family planning and domestic violence. Use of modern contraceptives has increased and community members speak of reduced gender-based violence. And these are just 2 examples of the many projects that we have proudly supported and worked with many of you on this conference call. What will we do today? And I very much look forward to this. We will reflect on how we can learn from experiences from work done across sub-Saharan Africa and in Canada to improve maternal and child health and sexual and reproductive health. We will learn more about different innovative ways communities were engaged. For IMCHA and IDRC, this type of learning exchanges is so important, and I have no doubt that today's event will be very fruitful, and I look forward to hearing from you all. Once again, on behalf of IDRC and our IMCHA partners, I wish you excellent deliberations and exchanges. Working with communities in Canada, Africa, and around the world offers sustainable paths to improve the health of women and children and the entire society. Thank you very much. Back to you, Nappy.
Thank you very much, Ariane. Now, we are going to move to the plenary session with a presentation from Dr. Ron Siemens on the community engagement component of the work of the IMCHA team. He is the Canadian co-principal investigator of, That's what the team is doing in Mozambique. But let me first say a few words about Dr. Siemens. Dr. Siemens is a pediatrician from the University of Saskatchewan. He works at the pediatric emergency department at the Children's Hospital in Saskatoon. Ron has been working with his Mozambican colleagues at University Lorio and the community of Natikiri since 2010. He began by helping develop a curriculum in community-based participatory action research at University Lorio. He then became the Canadian co-principal investigator on the IMCHA initiative project, with the ALERT Community Prepared Hospital Project. He is now continuing the partnership with Natikiri community, University Lorio, and a local chicken raising business in a family income generating project entitled Project Frango. Global health and community engagement have been a major focus in his career. He has practiced and worked around the world, including in Nepal, Pakistan, Ethiopia, Haiti, New Zealand, Bermuda, and Prince Edward Island and Saskatchewan here in Canada. Ron's passion is to build strong partnerships which support grassroots community endeavors that can be scaled up across countries to improve maternal and newborn care. And last but not least, Ron is father of 5, including 2 sets of twins, and has 6 grandchildren. Please note that there will be a time for question and answer at the end of the presentation. However, feel free to type in your question in the Slido Q&A tab as he is presenting. Ron, the floor is yours.
Thank you very much, Nappy. Just wanted to say welcome to everyone. And it's been just a fantastic opportunity to work with the team here. And I'm just going to open up my presentation here. I thought I should probably go and look at a number of videos by President Obama to know how to speak, but I think the only thing we could take forward is yes, we can. I think that's a big part of community engagement. Yes, we can. So let's start by short introduction. Nappy, thank you very much for giving me a short bio there. I'm the co-principal investigator in the Alert Community Prepared Hospital Project. And the focus of this conference today is to do a deep dive into community engagement. We're going to tell you a bit about what we're doing, but we also want to learn from you around the world what you're doing so that we can find out what's been done and see what the future holds for community engagement. My goal over the next 20 minutes is to share the challenges and successes that our project went through, and then allow some time in the question and answer period, as well as in the breakout groups for further discussion in this area. So that by the end of this conference today, you'll really be encouraged, energized, and really empowered to move forward with community. And our project, as the name implies, Alert Community Prepared Hospital, took 3 foci of how to approach the fact that women and children were dying in northern Mozambique, and how can we help them? So we looked at ways to improve the community education, transport to the hospital, and also to improve the clinical care given at the hospital and the resources available at the hospital. So this project has been running from 2016 through 2020, and it's just moving into its final stages now. So next slide. This has been funded, as you know, through the Innovating for Maternal Child Health in Africa initiative. The IMCHA initiative team has been so good to work with and so enjoyable, and it's been really innovative to have a my principal investigator, Dr. Celso Bello from University of Lirio in Mozambique as the main lead, myself, and the decision makers being the Provincial Health Department in Mozambique. And this team together, along with support from the African Population Health Research Center, has been very helpful as we move forward in developing this project. So I'd like to thank all the funders of the IMCHA initiative, which have been mentioned before, Global Affairs Canada, Canadian Institutes of Health Research, and IDRC. Next slide, please. So I think the most important thing about community engagement is context. So let's set the context. Where some people may not know exactly where Mozambique is. It's in southeastern Africa, as noted by the arrow here. And if we focus in a little closer, it's just above South Africa, and it's east of Zimbabwe. And we live in and work in, the University of Lirio is in Nampula, just outside of Nampula, actually in a rural area that is called the Natakiri Administrative District, and the smaller area called the Mureri Village. Mozambique has 30 million people. It's rated about 123rd in the world GDP rankings. It's rich in agriculture and natural gas, coal, and precious stones. And what we'd like to do with our project just outside of Nampula is tell you some of the lessons we've learned from this. So I'm just going to go through a few of those lessons so that we can be all on the same page about what seems to have been working for us. The first learning point was to build on past successes. This lady is Dr. Jerry Dixon. She is my mentor, and she was a team director in our Southern Mozambique project for 20 years. I was working there with her, and she was very highly regarded in the area of community engagement. And when the new University of Lirio opened 13 years ago, she said, why don't you go up north and check this out, Ron? So she sent me up there, and her recommendation opened doors of communication and collaboration, and we're able to start at a run. And so don't try to reinvent the wheel. Collaborate with trailblazers who are already doing things. And so build on your past successes, see what others are doing, and jump in and help out. Second learning point was to connect with a local team who's has similar goals. This is a picture of two of our team members, Kara and Nazmi, who are in front of the Faculty of Health Sciences at the University of Lirio. And University of Lirio is the first national health sciences university built in Mozambique, in northern Mozambique. And it's really dedicated to community engagement to the point that every single one of their students is part of the One Student, One Family program. So whether you're in dentistry or medicine or optometry, you are given a family to work with on the first day of your arrival on campus, and you stay with them for the whole 4 to 6 years of your training. Every 2 weeks, you go to that family and you share some local health information, and you learn about what life is like in the community. So this partnership with a dedicated team in Mozambique was vital to us. We started off, as mentioned, with a small research project to a partnership project to find out what does Uniliro need? And they thought a focus on research. So we brought in the Community Participation Action Research Curriculum, and that developed student projects. The student projects brought out some research gaps in maternal and newborn health. And so we were well positioned when the IMCHA initiative was put forward to apply for this, and the team was ready, and we've had quite a number of wonderful opportunities to work together because of that. So connect with a strong team in the local area. The third thing we learned was that context is vital. You need to spend the time to understand who you are in being involved with. in Mozambique, there are elected officials and traditional officials. And this is a picture of the traditional leaders and some of them. And this is called, the main leader or king is called a regulo. And this picture is all of men. One woman sits on this committee. So we went to the regulo, we sat down and said, we would really like to discuss with you what's going on in the community and how we might be able to work with you to move things forward. And they were very forthcoming, and we had great discussion, and they're very supportive of us working with them to aid their community. So you would need to, first of all, engage the leadership. Next thing we learned is there are named leaders, there are elected leaders, but who does the community truly get behind? This picture now, slide number 8, is Mr. Carlos Poecki. I can't say enough about this gentleman. He's 80 years old. He's a lay leader in the Catholic Church. He's around everywhere on his old motorcycle, sharing and working with people. He's got a lovely heart, and the people of the community really rally behind him. He's the chairman of the co-management committee. And the co-management committee, I'll take a minute to explain to you, is a hospital and community committee. Now, it's not like a hospital community committee in Canada where you have 15 health workers and one member from the community. In this committee, you have about 60 people around the table, and 55 of them are community members, each one from a representative from a local health committee, and 5 of them are hospital workers and leaders. And this team gets together to ensure quality healthcare is given to the community in a way that it reflects what the community needs and how they can best be helped. So we connected with Mr. Poecki, and he has been vital to the successes of our project. So really find the true leader that the community rallies behind. And the other lesson we learned was you have to liaise closely with systems that are present at the time. We liaise closely with the Mozambican health system. We brought no standalone interventions in. Our goal was to always have Mozambican teachers, next slide, present to Mozambicans using the local language and using Mozambican policies. There are a lot of wonderful things that the Mozambican government has written up, great policies, but it's very difficult to get them into place. And so our project really focused on that, and it made a huge difference. So next slide, slide number 11, shows a list of the lessons that we have learned. I just want to go back over that again. Really build on past successes, partner with organizations with similar goals, learn the context, meet with local leadership first, find the leader that the community rallies behind, work within established systems to really help the community move forward. So I want to get a little bit more specific now to the next slide with our community engagement, how it started. I think under the support from the IMCHA initiative, we did a baseline study. Sounds kind of technical, baseline study, but what we basically did was got members from every group in the community. We got adolescents, males, females, young men and women, family leaders, community, traditional birth attendants, traditional medical practitioners, grandmothers, grandfathers, got them into separate groups, and we asked them the question, why are women and children dying in your community during pregnancy and labor? And they sat down and they thought about that, and they discussed that, and they had lots of suggestions. And these were all written down. Then we spent time prioritizing which are the major problems. And then we brought all the groups together, took all the priorities, and developed the our 7 strategies to try to address these difficulties. And we developed these 7 intervention strategies that were things that the community really felt would make a difference and that we ourselves felt would make a difference as well. So we did not do research on this community. We did research with this community. And I think that's a big, a small word change, but a big difference. So we really had a lot of time working with people and developing this, and we spent a lot of time, slide 14, under the mango tree talking about life and getting really trying to understand as best we could the context of the area. So the 3 main things that, again, that we focused on were community education, transport to the hospital, and getting to a place where there was good patient-centered care with no fear of these illicit charges or bribery. And I'll go into these strategies a little bit more. It's the community engagement, the transport, and the patient care. But next slide, slide 15, shows one of our focuses. We really had a focus on adolescents. Why? Because 50% of the population of Mozambique is under 20. It's a very young, vibrant country, and they just have this energy that is infectious. And so with all the young people, our focus was on the adolescents. So I want to go over our first strategy in working with the community. Next slide, number 16, shows, it's a little bit of a dry slide. It basically states the strategy. Support knowledge and practice of sexual and reproductive health with a focus on rights, family planning, contraception, education, adolescent sexual health. You know, strategies, they always sound so prepared and so sort of written out. And what is real life? What do you do in real life? Well, I'm just going to go through what we did in real life. We went into the high school, and here was a great Mozambican policy. It's called Geração Biz. They said the busy generation, you know, the adolescents are always doing things. And this was a policy that the Mozambican government had set to try to pass on sexual reproductive information in schools. And it had sort of fallen into disrepair. So we took time to take 30 youth from the school and several of their teachers and give them teaching in how to be peer champions, how to be activists in the school, and regarding sexual reproductive health, brought them back into the school, energized the Geração Biz group, and it's been quite helpful. And you'll learn more about that in the breakout group on adolescence. But then, you know, all the kids in Mozambique aren't in school. But they do have very formative initiation rites. Every child in northern Mozambique goes through initiation rites as they enter puberty and through puberty. And so what we did was meet with the initiation rites teachers and say, you know, would you involve teaching about modern contraception in the initiation rites? And they were very open to this. And what we're trying to do is have young people learn about contraception, and it's part of their tradition, not part of something that other countries have brought in, the white person has brought in for them, but it's actually part of local tradition. We then went to each of the local health committees, and again, a great Mozambican policy, small volunteer groups in the community that teach health issues. There were 6 not very well functioning committees in the area. And now after 4 years, there are 20 strong groups who are really making a difference. And one of the ways they made a difference was through theater. And I took a student with me to one of the theater presentations, and it was the most formative thing he'd been through. We were on a bus, we traveled into the bush. Nobody was around. We set up a boombox. Suddenly, 150 people were there. The theater group was dancing, singing, and sharing sexual reproductive health messages through theater, and it was very well received. We also sent key messages out through radio. We gave radios to the communities. We developed listening groups so that the communities could discuss what came through on the radio. And the final thing was traditional birth attendants. With the WHO strategy that says babies should be born in health centers with trained personnel, the traditional birth attendant's role has dropped off. But we have these great knowledgeable hands available. And so we connected with them. We now have 80 giving monthly reports of what happens in the community. And we have been able to open up the hospital delivery room so that the traditional birth attendants are now welcome to come and accompany women to act like a doula would here in Canada, or accompany the laboring woman, and really another set of knowledgeable hands available to help in the delivery room. So some great opportunities in the community. The next thing we did was, there are no roads in this area, lots of paths, but no roads. So people were walking 3 hours while in labor. There's a tick box on the obstetrical delivery sheet that said, where is your previous child born? And there's actually a tick box for on the road, because so many babies were being born at the side of the road. So this is a great story. A Mozambican welder and artist living in Canada developed this trailer. We then tested it out on the bumpy roads of the back prairie here in Saskatchewan. And then the plans were taken to Mozambique, built with Mozambican materials by Mozambicans for Mozambicans, and they are now deployed in 6 different communities in the area, bringing women quickly and efficiently into the hospital. So we're really pleased about this part of the project. And then the final one was, not the final one, but the last one I'm going to talk about specifically is a strategy 6, which was to support Mozambique's anti-bribery strategy. Healthcare is free in Mozambique, but women would be left to labor all alone if you didn't slip extra money to the caregivers. There are long waits in the emergency room if you didn't pay that extra charge. Prescriptions weren't being filled if you didn't pay that extra charge. So what we did, we took a developed Mozambique policy that had just come out. We were the first hospital in Mozambique to use this tool. It's called the Health Facilities Challenge Survey Tool. It's the English translation's a little clunky. It's better in Portuguese. But this is a survey tool where the co-management committee got together. They listed specific areas of conflict between the community and the hospital. They developed a clear, concise plan on how to deal with those problems. And the results of that were that bribery and illicit charges dropped significantly. The community members started to volunteer in the hospital, and traditional birth attendants were allowed to come into the delivery suite. So all these things were just amazing, just be using a simple tool to get people together to talk. So as was mentioned, what happened, we've had great success in improving community health and maternity health, but the real number one indicator for health around the world is family income. So our next project is called Project Frango, Frango meaning chicken in Portuguese. We networked with a local chicken raising business, and we've raised money to build a chicken raising training farm. 8 families a year will be trained to raise chickens. They'll bring 20,000 chickens to market every 7 weeks, and the profits will be banked for those communities or those families, so that at the end of 1 year, each family will have enough funds to start their own farm, and they'll be supported by the chicken raising company. And one part of the profits will maintain this farm, and another part of the profits will go and pay for the gas and maintenance of that motorcycle ambulance system. So you get a self-sustaining farm, self-sustaining motorcycle ambulance system, and every year we're training 8 more families and improving the income, in which then trickles down throughout the whole community. So we're very excited as they've just found water on the site, and they're building the farm as we speak. So we're very pleased about that. So I wanted to take the last 2 minutes and say, what can we bring back to Canada? Because we're not just working overseas, and people always say, well, what do you do in Canada? What comes back to Canada? Well, every year we've taken 4 to 6 medical students with us to Mozambique, and I'm hearing comments from them that say, I've observed many experiences that will influence and change the way I think and make choice in life and practice medicine. Others say massive benefit of global health with just small changes. It's been formative for me. So these students come back with ways of learning they've learned ways to work with disadvantaged populations who have low resources, and we have numbers of opportunities here in Canada for them to work, and we've seen lots of these students move into rural and remote areas and support our system here. And we didn't only take students there, we brought students back, and we're developing our own Mozambican curling team here at some point. We hope to get them on the curling circuit. But it's been very good to have a back and forth connection. I'd like to share just this last few slides, something about what I've learned through all this. One of the big things I've learned is just the joy of community. It's amazing how in this pandemic, you hear people say all the time, we're in this together, we've done this together. And seeing community work in Mozambique, seeing these people strive to improve all about them and to volunteer hours and hours and do hard work to support their community has been just amazing to watch and learn. The other thing I've learned is, there's a difference between abundance and enough. We need to know here in Canada we have enough. How can we share with our world? So I learned an understanding of constraints. Sometimes it's just not there, and you need to know how to work with what you have. Also, I learned the power of your mother tongue. In Mozambique, I speak Portuguese and I understand, but I don't get it really deeply. So now in Canada, whenever I'm speaking with someone where English is not their first language, I always get translation services. So when I'm sharing medical things with them, they get it deeply and understand. And finally, tradition. Tradition is rich. Stop, listen. And this is so important in Saskatchewan as we work through truth and reconciliation. Tradition has a lot to teach us. And the final learning is the final slide, number 24, everyone has dreams. And how could we work to help people, each and every one of us, fulfill our dreams? So thank you very much, and I'm happy to answer any questions. Go over to you, Nappy.
Thank you very much, Ron, for sharing this experience, very rich experience. So now we're going to move to the Q&A session. Again, feel free to ask your question in the slide or Q&A button. So Ron, while people are typing in their questions, let me ask you a question to start. You indicated that getting the trust and building getting the trust and buy-in from the community takes time. When did your team, realize that you were winning and that the people from the community were on board with you and were ready to move the project forward and onward?
Well, thank you, Nappy. Good question. I think when one of the older male members of the co-management committee came to me and said, our young girls are getting married way too young. They're dying, and we need some help. How can you help us? Please help us. And that's when I knew we were in and ready to, and we're being accepted. And that came several years after we first met, and they told me, we're happy to work with you, but lots of people come and tell us that they never come back again. And so I knew we were succeeding and accepted when we had history and we had that question.
Very great answer. Thank you. Now let's go to the Q&A chat box. Heidi, is there a question? Do I have any questions in this chat box?
Sure, yeah, thanks. In the same vein, there's a question, Ron, for you that asks, how do you measure the impact of community engagement interventions?
Sure. The way that we did it in our project was interviewer-led survey. So we had the opportunity of working with the University of Laurier. They have lots of students going out into the community regularly. And so we had a ready-made group who would go out, meet with community members, sit down one-on-one, walk through a questionnaire with them. And we learned quite a lot from that. And then we also had focus groups that we met with as well and we tried to get focus groups from all parts of the community. So those are two of the ways that we used to measure that difference. A third thing we did was look at the dry, straightforward hospital statistics, and to get statistical things, and then we used the more subjective information from the other things.
Thank you, Ron. Heidi, more questions in the chat?
Yes. A question from Leonie here. Did the research project integrate any scaling strategies to expand interventions once they were shown to be successful, for example, in other communities?
Yes, thank you. We worked with the director of the provincial Department of Health, and so everything that we did, we ran through them, and we brought this information to the national level as well through them to try to scale for scaling purposes. And we're in the part of our knowledge translation part of our project right now. So we've developed policy briefs for the government to say, this is what we did with the motorcycle ambulance system. For example, the government bought, I think it was 300 motorcycle ambulances from China about 4 years ago. They read on them, they say these are meant only for asphalt. And a number of them were delivered to Nampula, and we never saw them again. They just broke down and were useless. So we went and talked to the government, and they said, we want something that's going to be maintainable. And so our policy brief talks about maintaining how to maintain a system. So really what they're most interested in was how to maintain. So yes, that's how we're really looking at scaling up through our policy briefs and further discussion with government.
Thank you. I think we have time for one more question, maybe two. Heidi, let's try one more at least. Ron, if you can make short, not shorter, but short answers, then maybe we can put two questions there. Let's try.
Sure.
Heidi, go with it.
Sure. A question about how do you see the role of men, the local men in Mozambique, in improving maternal and newborn well-being in Mozambique?
Sure. At this point, this is always sorry, Nappy, this is not a short answer. Men are not welcome in the delivery area. When we try to involve the spouse, there have been some difficulties because women see a lot of this area as their purvey. So we have been working closely with the local leadership, both male and female, to bring partners in. We're pushing to have a partner accompany and be with the mom. But at this point in Mozambique, it's still not that sort of as accepted that the husband will be totally involved in the pregnancy as you may see in some Canadian situations. So we haven't been as successful with that, but we are working toward that.
Thank you. Can we maybe have one more? It wasn't that long, Ron, but it was very informative. Heidi, can we add one more question, maybe one?
Sure, lots of questions here, and I think we can dig into some of them in the discussion groups as we go into the next session. But one last one here. How did your organization reach out to other parts of Africa, for example, Ethiopia? And what does it look like in other parts of Africa, if you have any thoughts on that?
Sure. the way that IMCHA works is that it has 19 projects across sub-Saharan Africa and health organizations, 2 health organizations that oversee them. And so we connected through the African Population Health Research Center, which I strongly recommend. They're very supportive, very knowledgeable, very good at teaching, and very good at having connections with government. So our things we're sharing with them, and they're sharing with their in committee when they meet with groups like the Southern African Coalition and things that get together at a high level. They can get our information to a higher level. So our research is not sitting on a desk. It's actually going to the APHRC, and that's going to various parliamentary committees in many different countries. When it comes to how things are across Africa, I think they're the best ones to give you that answer because they are Africans working in Africa for Africa.
Perfect. Thank you very much, Ron, for referring and acknowledging the role of the Health Policy and Research Organization, HPROs that are part of IMCHA model. Very thank you. I'm sure there are a lot of more questions there, but be reassured that everything is not lost. You will have a lot of chances to discuss more in detail, like Heidi said, in the breakout sessions, which we are going to go in right now. Let Heidi give you some practical guidance on how this is going to work. Heidi, back to you.
Sure. So we're going to go into different discussion groups, 5 different groups, and in each group there's going to be a designated moderator lead who's going to introduce the topic, they're going to give a short presentation, invite some other speakers to speak. Those will be brief presentations, and then we're really turning the ball over to participants to contribute to the discussions, to ask questions, to share their own learning and experiences. And you're going to be able to raise your hand and type comments in the chat box. You're going to find yourself in a Zoom meeting. So how can we get there? At the top of your screen on the right, you'll notice an icon that has kind of 3 people, little heads that are together. And if you click on that, you'll see a drop-down menu where you can select the topic of your discussion. When you do that, you're going to a new tab is going to open, and it'll bring you to the Zoom meeting for your discussion group. When the meeting is done, and when the discussion group is done in about an hour, you close the tab, and then you're going to come back to the plenary session. So without further ado, let's go to the discussion groups. We'll give everybody a few minutes to get there before we start. Enjoy your session.
I hope you had a great sessions, and thank you for your patience if you have been waiting a little bit for everybody to come back from their sessions. I trust you had very interesting and enriching discussions in your groups, and we'll talk to that again a bit later. But first, after all that hard work, we are going to watch a short video about a traditional First Nation jingle dress dance performed by Kenesia Tutsis from Pound Maker Treaty 6 First Nation of Canada. Kenesia will explain the profound meaning for women and children as she performs. And I know she's joining today for the event. So greetings, Kenesia, and off to the dance. Thank you, and I'll see you too. I'll talk to you soon.
The jingle dress dance originated from the Ojibwe people of Eastern Canada. The style of dance was shown to a grandfather in a dream during the time of the Spanish flu. His granddaughter became ill, and he was directed to create a dress with rows of metal cones on it for her to wear. This dance represents healing, as it had cured the girl of her sickness. The song I will dance to today is called the Side Step, and it is the healing song for the jingle dress style of dance. The sound the jingles make are medicine. Today, I dance in honor of creating healthy mother-child relationships. What was told to me in my Cree culture is that children choose their parents when in the spirit world. From conception to the time the child is born, the mother is to be taken care of and looked after. Her emotional and physical well-being are important to look after as she is growing a child within her. At this time, the mother and child relationship has already begun. The child hears the mother's heartbeat. They hear their mom's voice. Your mother is your first home. When the child enters the earthside world, they have already gone through a very tough transition, birth. From now on, the mother-child relationship and bond is to be paramount. This connection is still spiritual and physical. From breastfeeding to cuddling to napping together, the mother and child grow together in their own first times as a child and mother. The Cree word for child is awasis. Awasis. This word refers to the child as being a pure spirit. Our job as mothers is to take care of the little pure spirits that are lent to us by the Creator. We heal our families when we heal ourselves. Take care of yourself as much as you take care of your family. I pray for the safety of each one of your families. Hi. Thank you.
Wasn't that beautiful and powerful? I would like now to call on the leads of each of the breaking groups to share with us the key take-care points from the discussion in their groups. I would like to please ask each to keep it to 2 or 3 minutes. Let's go by the order of the group. So first group, community voice was moderated by Dr. Friday Okonofua. Friday.
Yes.
Thank
you, Nappy.
Yes, please go ahead. 2-3 minutes.
It was a very interactive session. We had presentations from 2 groups, one from Canada, who worked on the developmental challenges facing babies born to mothers who are HIV or who are drug addicted. And then the second was a community-based project in Nigeria that was aimed at increasing women's use of primary care for skilled pregnancy care. And we had a lot of discussions and presentations. The presentations are very good, and I think we've captured them and we'll be able to report them subsequently. But let me just summarize some of the lessons and some of the thoughts and ideas that came out of the presentations and then the discussions. The first is that, for community voices must be heard in any project where you seek community engagement, and I think that Amanda made a very important point that when you are doing community-based research, you should endeavor to listen more than talk. Listening will enable you to know what the communities want and what their problems are, and it's only by understanding what their problems are that you're able to provide a solution. So communities, allow them to talk while you listen. And then from there, you can identify some of the challenges they have. And then secondly, in designing interventions, you should, as much as possible, involve communities in all phases, and indeed allow them to lead. Community leadership, that will enable you to understand all the elements of the intervention of the project so that they can integrate it, and it's more likely to be successful and impactful if you allow them to lead the process. So that even when you stop the project, then the chances of sustaining the project activities over time will be increased. So that was the second point. That is that we should allow the community to lead. And then thirdly, I think a very important point came out that in looking at the researchers that need to go to the community, that will engage community, we should use a multidisciplinary research approach, such that experts from various backgrounds who have various experiences and skills in entry communities will be engaged to work on the project. So that whenever there are difficulties, you have somebody you have missed who can help you solve that problem. I think that was another very important point that came out. And then fourthly, we identified the need for community gatekeepers as an entry point. Those who were introduced, unless of course you do that at the very beginning, knowing the stakeholders who are important to engage, and then also knowing ways to engage them, because every community is different. So whereas you have used my approach to your own particular community, if you are going to a new community, you should try and identify what approach are specific to those new communities. And one of those approaches is to be very accurate in doing what I call community stakeholder analysis to be able to identify gatekeepers. Because for all we know, we are just the technical experts, but the community leaders are the ones who will know how to use. And then the last and second to the last is that when we are
just 1 more minute, Freddy, please. 1 more minute.
How many more minutes?
One.
How many more minutes?
Just
1 minute. Okay,
just
good. Okay, good. That, you know, technical issues should be explained in simple languages so that community will understand and follow you up with the process of implementation. And finally, they talked about how do we expand and scale up and replicate some of the things we found in these two community projects. And they are very, very, everybody talked about scaling. How do we ensure that what we have learned can be scaled to other regions of the world, can be learned by other communities, can be used for policy uptake and policy engagement. I think, thank you very much. I think those are the lessons from that particular group. Thank you very much.
Thank you, Friday. I know the topic is very passionate. It is very interesting, and we get carried out as we start speaking. That's what we like doing, and that's what we do best. Very good. Thank you.
Thank you. Thank you.
Now, group 2, Dr. Ron Siemens, do you want to think about your group and the discussions? Over.
Yes, thank you all who were involved in the group. We had excellent discussion. Some of the key points were that was brought up, a quote from, I don't quote Jessica exactly, but one of our medical students said that, you know, tradition and culture is not an add-on and a checkbox. I went to a special cultural event, check. I did this, check. Tradition is actually a person's life, and culture is a person's life. And so as I am learning to be a better practitioner and a physician, culture is not an add-on, it's life. And so I was really impressed by that comment. Marie from Rwanda gave us an excellent understanding of how the Rwandan government has formally connected with traditional healers to try to ensure that the traditional healers are involved in the care of Rwandan people, and that's done in a way of mutual discussion. And that was very strong. So very pleased with that. Jaibo, our sociologist from Mozambique, gave excellent discussion on how our project is working with traditional healers, and the comment was brought up, well, how do they give reports if they're not literate? And we mentioned that our reports are visual and picture based, and so that helps. So it's important to do that. So those are some of the points that came out of working with tradition. And James, our elder from Dillon, gave some wonderful examples of working with people on the land in northern Saskatchewan. Thank you.
Thank you very much, Ron. Now, off to group 3. I heard that the group on youth got very lively discussion. So, Celso, can you brief us on what happened in your group?
Thank you very much, Nafi. In our group, we shared lessons that we learned from our IMCHA project in Mozambique on how to engage youth in sexual and reproductive health. And there are some highlights that I would like to share. The first one is that it's important to work and strengthen existing youth platforms. In our project, for example, we were working with Beast Generation. Dr. Ron talked about it. And we trained them, the students, the teachers, we gave them the tools they need to work, and that worked very well. The second lesson was that we can use the tradition and the culture interventions to make a difference in engaging adolescents in SRH. And the example was the initiation rites. I think that was already explained before. And the third lesson was about to be successful engaging adolescents in our interventions. We need to engage them as active stakeholders. Now, the adolescent must be part of the intervention, the project to reach other adolescents. It's an effective way, having adolescents talking to other adolescents as peers. So it's important to involve them as stakeholders. The fourth lesson was about some gender approach differences when approaching adolescents, boys and girls. And it's important for us to remember that boys are different from a girl, and they have different necessities and different ways of understanding sexual education and so on. So, and they have very different roles now in our relationship, and it's important to be sensitive to that. Thank you very much.
Thank you, Celso. Moving on to Group 5, Ms. Sean Fitzgerald, do you want to talk about your group on gender? Talking about gender and youth, let's continue on gender with your group.
Thank you very much, Nappy. Yes, we had a wonderful group discussion looking at gaps to address gender inequality. All of the discussion was in the context of maternal and child health, and most of it was in the context of accessing health services. So we heard from two IMCHA projects, one in Ethiopia and one in Tanzania, as the presenters, as the co-facilitators, but then we also heard some reports back from Burkina Faso and from Rwanda, which it was very interesting because there were a lot of similarities in the reports, in the issues that people were raising. So I think what rose to the surface most clearly was that one of the most common and most effective ways of addressing gender inequality is engaging men in the community to get involved in addressing the barriers that women face in reaching and accessing health services. So some of these barriers, the more common barriers, included barriers to transportation, access to transportation, decision-making, who's making the decisions. For example, does a woman go to her prenatal visits, postnatal visits? Where does she deliver her baby? Decision-making is key in determining how she accesses the services. And then there was quite a lot of discussion about the stigma and shame that may prevent men from getting engaged. So everyone agreed that it's very important to engage men in maternal and child health, but they're also acknowledging that there are a lot of cultural challenges there, and that you really need very strong community leaders and champions to overcome the stigma and the embarrassment that men might face by getting involved in maternal and child health. One of our participants talked about this and put it in the context almost of being bullied, we asked him, well, what do you think we should do about it? I think his answer was, we need to do more of it. We need to get more leaders, more champions, encouraging men to get more engaged. And I've asked my participants to come in later if I miss something, but I don't know that they'll have the opportunity to do that necessarily, except through Q&A. Anyway, I'll just close with, we did a little bit of a brief discussion on what other gaps might there be in addressing gender inequality and community engagement. One important point was that at the beginning of any intervention, it's really, really, really important to understand the impact of what we're doing on the status of women. So understand the status of women and understand the impact that anything we do might have on them. And also that often the barriers are related to structural barriers and can be addressed through the political level. So I will close there. Unfortunately, we did not have any Canadian experience shared in our group. So it was all from colleagues in Africa. Thank you.
Thank you very much, Sean. So as we knew, there will be a lot of interesting discussions in the group, and I'm glad you were able to share experiences across countries, across different activities, but still see a lot of similarities. Wherever you work, these thematics are the same everywhere. And so it's good that we tackle them together. Thank you very much. Now, you should be seeing on your screen some Slido questions. And please take the time to respond to the questions. That will be very helpful for us for planning future events. We are now arriving at the closing remarks. I would like to introduce Dr.
Sorry, Nappy.
Yes.
I'm just going to cut you off. I think you forgot to invite Jennifer.
Oh, sorry. And she was my group. Come on. Jennifer, I talked so much with you that I already forgot to sorry about that. And sorry, participant. We cannot forget group number 5. Please, Jennifer, go ahead and do your debrief for us, please.
Thank you, Nafi. That's fine. I know because you were with me, so you thought I had already presented our points. Thank you. And our session had very interesting issues about incentivizing community health workers and how the community can engage with these community health workers. There were 3 or 4 major points, lessons that we learned. One, the issue that came out was mainly, since we are in low resource setting, can we really focus on non-financial incentives? And this could be like recognition of the community health workers, giving them more training, giving them things like T-shirts, like kits, which have those things that identify them from the rest of the people, get more training in issues of training, nutrition, hygiene. And I think one of the participants mentioned that it worked well in Mozambique, and it increased on the number of volunteers that were ready to do this work in the communities. And the other thing that came up clearly was that we need to invest a lot in training these community health workers because they do a lot of work in the communities with the limited knowledge that they have. So we run a risk of the health of our people because they don't have that much knowledge in the work that they do. The other thing that came out was that it is interesting that it is the issue of volunteering because most of community health workers are women, and this was basically on the gender responsiveness issue. What could be the cause of this, and what does it mean? Why do we have mostly women that do this kind of work? But one of the participants further mentioned, and which was an important point, that what is missing within the community engagement is leadership within these community health workers. And this leadership could be responsible for issues like monitoring, supervision, ensuring that these people are trained, and could be a good link between the community and the health system. But the last point that came up and actually raised raised to us some thinking is we should drop the idea of saying we need money to support the health system so that they are able to incentivize these community health workers. So I think that these are the issues that came up in our session, but it was a very interesting session and the discussion was very good. We didn't want to come out. Although something happened towards the end, I almost dropped out because of the network, but I'm happy I'm able to participate and lead this session. So these were the issues that came up, and I hope they are very good lessons for us concerning incentivizing community health workers. Thank you, Nafi.
Thank you very much, Jennifer. Apology for not mentioning your name earlier. That's what happens when you have the person all the time.
That's okay, Nafi.
Okay, so starting to the next session now, you should be seeing now on your screen the slide of questions I was mentioning. And we really appreciate if you take the time to answer those questions because they will help us plan for future events. So we are now arriving at the closing remarks. And I would like to introduce Dr. Meghna Ramaswamy, Director of the International Office at the University of Saskatchewan, for closing remarks. Dr. Ramaswamy, the floor is yours.
Thank you to the conference hosts and the organizers for the very kind invitation to say a few closing words. This has been a very exciting conference, and the University of Saskatchewan is grateful to be part of it. Now, much of poor health is caused by poverty, gender inequity, lack of education, social marginalization, and lack of access to healthcare services. In this essence, the United Nations Sustainable Development Goals, all the SDGs, come into play as SDG 3 explicitly relates to ensuring healthy lives and promoting well-being for all by 2030. Issues related to health extends beyond the borders of the health sector and requires commitment of multiple sectors. Dr. Siemens' work on maternal and child health in Africa assessed the impact of community-owned motorcycle ambulances to provide access to reproductive health and hospital emergency services for pregnant women in Mozambique. Building on these strong partnerships with local actors, NGOs, and the government, Ron's project was able to enhance emergency obstetrical and outreach services and advance efforts to eliminate illicit charges to clients. Many adolescent and young women have acted as family health champions and received local support to pursue education. Now, community engagement, as evidenced by Dr. Siemens' project in Mozambique, enhances community cohesion and allows the community to exercise power to shape decisions and have ownership over the outcomes that will ultimately impact them. Successes and lessons learned from such shining examples illustrate how communities, governments, and universities can achieve maximum impact on their social investments. Successes and lessons learned from Dr. Siemens' projects can be potentially applied to other global community settings as well. Projects such as these, which are grounded in a human rights approach to maternal and newborn health and focus on eliminating inequities that lead to disparities in access, quality, and outcomes of healthcare within and among countries, are what brings communities and countries working together. Partnerships such as these need to be celebrated as they spur dialogue and mobilize multidisciplinary synergies and enable science to be conducted with transformative action in mind. I would like to close by saying that the International Office at the University of Saskatchewan, which has supported Dr. Siemens' work in Mozambique, will be hosting a virtual People Around the World conference on the 2nd and 3rd of February 2021. This conference will focus on how we as a community can re-emerge stronger and together and help localize the global sustainable development goals by bringing meaningful impact to our communities. We welcome you all to participate and attend the event. I would finally like to thank Dr. Siemens and his team and all of you for attending this conference, for your alertness, agility, and engagement. Thank you once again, and I hope you and your loved ones are safe, healthy, and well.
Thank you very much. Please, again, don't forget to fill out the Slido questions that are on your screen. You just have to go click on the Slido button at the top to answer your questions. Now, Dr. Montasser Kamal, Program Leader of the Maternal and Child Health Program at IDRC, will give his remark. Montasser, the floor is yours.
Thank you so much, Nappy, and thank you everyone for such a wonderful event and for your engagement. It's been a really very interesting conference, and I'm delighted to have been engaged in this. There are many take-home messages from today, and I will not go through all of them, but I would like to just highlight a few of them before I give my sincere thanks to everyone who has been engaged in today's event. From the presentations and the discussions today, it's clear that knowledge and expertise from the community must be integrated in research, not as an afterthought or to just apply solutions that are designed by outsiders, but that those solutions are crafted and thought about, conceived and implemented jointly between the research community, civil society, and of course, governments. The world is one place. If we had forgotten that, COVID-19 reminded us. that the world is one place. Canada and Mozambique may seem far in distance from each other, but they are close in their thirst for better approaches to address system gaps and failures and move women and children from early death and morbidity to surviving and thriving. This work takes collaboration between government departments and supporting under IMCHA, to collaboration between government departments in Canada. But for it to be successful, our conference today showed that collaboration between the researchers and community is also key to effective solutions. But for that to work, we need more of a new breed of researchers and practitioners that understand how to work with communities and how to integrate knowledge from communities into scientific research. We also heard today that many, governments have good programs, they have policies, but sometimes they don't quite work as intended. Community-based research can bring these policies and programs to life to effectively help them deliver as intended to people in communities. These solutions are not one-off. They need to be a living learning and research is needed to continue to meet those needs as they evolve and change, as communities change all the time. I have taken so many quotes and key messages from everyone, from Ron and others, saying to build on past successes and start from the realities on the ground. From the working groups, reported by Friday, communities talk, you listen, we should listen, and allow communities to lead, give the space and the room for communities to lead. I was in the youth working group, and it's always a welcome delight to be in discussions where youth are not discussed as a problem, but as peers and as actors and actors in communities and active actors for their own destiny. I also really greatly appreciated the emphasis on arts and culture from our elders, but also from the examples from this research project and how arts and culture were integrated in the learning and the community mobilization and the joint thinking. This is part of life that is always very welcome when it is integrated into research and into scientific thought. Ron, the last point I take from one of the last points. One of the points that really also stood for me is the joy of community. Sometimes, of course, communities are not always joyous, but the joy of being in a community and getting that sense of working together, doing things together, is unparalleled, and this is something that can go be in common. We have in common in Canada and the rest of the world. This event was a great start to the conversation. Of course, it's not the end of the conversation and the exchanges and learning from Africa, Canada, and elsewhere in the world, but we're hoping the discussion will continue. We at IMCHA and IDRC will continue the conversation. We're planning more IMCHA webinars and events in the coming months. Next week, for example, several IMCHA grantees will be presenting during the Canadian Conference for Global Health. The first presentation will be on Wednesday, October 21st, from 12:30 to 1:30 Ottawa time, where IMCHA grantees will speak about building resilience and improving health in communities. I sincerely hope you will be able to join. IMCHA grantees are also continuing to publish material. You can stay up to date by following us on Twitter at IMCHA_ISMIA, by subscribing to our newsletter via our website, and of course by visiting our website regularly. As I mentioned, an event like this does not happen by itself. It happens by hard work and collaboration between many people and institutions. So before concluding, I would like to thank all of you for your active participation as participants and sharing your experiences and knowledge. We hope you have learned something today, and thank you for sharing your knowledge with us. I would like to thank the presenters in the plenary and the breakout group discussions for stimulating our thinking. And a special thank you to our elders who joined us to share their wisdom and experiences in community mobilization. We greatly appreciate your being with us today, and we hope we continue this connection in the future in our work on maternal and child health, adolescent health, and sexual and reproductive health. Thank you also for the translators and the team from Baldwin and Collaborative Video, who worked so effectively behind the scene to make this event a success and run very smoothly. Last but not least, a big thank you to the organizing committee at the University of Saskatchewan, namely Dr. Ron Siemens and Tova Dibvig. It has been a pleasure to partner with you to host this event, and we look forward to more to come. Thank you. Finally, thank you also to my own team and IMCHA here at IDRC. Special kudos to the IMCHA team, Dr. Nafissatou Diop, Heidi Monk, and Dr. Sana Nafa. Well done to the team. Well done to everyone. Thank you so much for being here, and keep safe, keep well, and we hope to see you again soon.
Thank you very much, Montasser. Again, please don't forget to fill out the questions on the Slido. Go up on the bottom of the Slido and click there to be able to access the Slido questions. For more information on IMCHA and our activities on the University of Saskatchewan's work or on the work in Mozambique, please refer to the information on the screen. So this is the end for today. On behalf of the IMCHA team, I hope you have enjoyed the event, and I would really like to sincerely thank you for your participation. Goodbye, and please stay safe and take care of yourself. Bye.